Marianne, would you like to start?
Everyone, and welcome to the webinar on financing and sustaining behavioral health interventions for older adults. This webinar is being offered by the Substance Abuse and Mental Health Services Administration, or SAMHSA, along with the Administration on Community Living, the Administration on Aging, or AA. These nations have come together to support the American Behavioral Health Technical Assistance Center. And Technical Assistance Center supports a partnership between SAMHSA and NCOA to provide technical assistance to the states and organizations as they implement behavioral health programs and services, such as those focused on suicide prevention, alcohol, and prescription misuse and abuse, as anxiety and depression. I'm Shannon Gawronski. I am a federal project officer with SAMHSA. I'm project officer for the current older adult grants, and I have been working with over 15 grants since 2007 that are in the area of serving older adults. Older adults grants are involved, the current grants are involved in cutting-edge practice, including integration with primary care. And another of my responsibilities is to work with 14 programs in the southeast part of our country who serve younger adults, but who work on primary and behavioral health care integration. And hopefully we will see more grants in areas specifically that address older adults. The tech assistance that is provided by the Center for American Behavioral Health includes 10 webinars, of which this is one, 14 issue briefs, and 5 Policy Academy regional meetings. As materials are developed, they are archived and can be accessed on the Administration on Aging's website as well as the National Council on Aging's website in the behavioral health sections of both of those websites. I'm pleased to welcome you today to this webinar on the important topic of financing and sustaining older adult behavioral health interventions. The webinar will focus on strategies and resources to implement and maintain prevention and early intervention programs and practices. Today's speakers will offer some examples of evidence-based models for older adults. The focus of today's webinar is on financing and sustainability. You can get information, evidence-based behavioral health interventions on the websites the speakers offer and through earlier webinars and issue briefs produced by the Older American Technical Assistance Center. We have several experienced behavioral health service researchers, providers, and funders to share knowledge and experience with us today on successful strategies for financing and sustainability. Now I would like to introduce our speakers, and then we will proceed on to the webinar. First, we'll hear from Alex McNeil. Alex is with the Center for Healthy Aging and National Council on Aging. Alex is working with the current Older American Technical Assistance Center, and she today will discuss findings from a sustainability study that advised her on and SAMHSA funded. Alex and her colleagues at NCOA and others looked at the sustainability of community older adult behavioral health services following the end of SAMHSA and Administration on Aging grants. Alex will review factors in the scientific literature and strategies from the field that contribute to sustainability. She will also brief you on a financial resource guide that is a great part of the NCOA report. And that report is available on NCOA's website in the behavioral health section. Next, we will hear from Shannon Gawronski. Shannon is an Aging Services Program Specialist with the Administration for Community Living and the Administration on Aging. Shannon is an advisor from the Administration on Aging to the Older Americans Behavioral Health Technical Assistance Center, and she will review the Older Americans Act and where it includes financing for behavioral health. Now turn to Jean Close. Jean is Technical Director the Division of Benefits and Coverage in the Disabled and Elderly Health Programs Group at the Centers for Medicare and Medicaid Services, or CMS. She discussed financing older adult behavioral health interventions through Medicaid. She will review Medicaid services, optional state plan services, waiver programs, and new options, including health homes and community first choice. Leslie Steinman will follow. Leslie is part of the Health Promotion Research Center at the University of Washington in Seattle. Leslie will discuss financing depression care in community aging through programs like Healthy Ideas and Pearls. She will tell us about the many financing sources used to implement and sustain these interventions, including financing from Medicaid, federal and state grants, and the United Way. Our presenter will be Stephen Ferranti. Stephen is the managing partner of Group Victory, LLC, and director of the Aging Academy and faculty member at Florida Atlantic University. Stephen will discuss financing for screening, intervention, and referral to treatment for alcohol and medication misuse, known as the SBIRT model. He will review the sustainability of BRIGHT, which was an adaptation of the SBIRT model for older adults in Florida and is currently still underway. He will review financing options used in other states for SBIRT. Following Stephen's presentation, Alex McNeil will step back in and offer a summary of key takeaway points from each of the presentations. Alex, give a takeaway. We will have about 15 minutes for questions. Please send us your questions anytime during the webinar. Type them into the chat box at the top of your screen. The purpose of this webinar is to advance understanding of the factors and contribute to accessibility of behavioral health interventions, to spread knowledge about public and private financing mechanisms that support effective older adult behavioral health interventions, programs, and practices. I thank all the speakers and our audience for your participation in the webinar today. The webinar will be recorded. The recording and slides will be provided to all who registered. Now to our first speaker, Alex McNeil from National Council on Aging. Alex?
Good afternoon. I'm Alex McNeil, the National Council on Aging. NCOA, as you've heard, is working with SAMHSA and AOA on this webinar series and related issue briefs. I will discuss findings from a recent study NCOA conducted with the assistance of SAMHSA. The study report titled Lessons on Sustainability of Older Adult Community Behavioral Health Services, and it is found on the NCOA website at the page offered on this slide. We Laban's definition of sustainability, that is, the extent to which an evidence-based intervention can deliver its intended benefits over an extended period of time after the initial external support from donor agency is terminated. So what happens after the initial grant? That's what we're looking at for sustainability. We read the literature to learn what factors and strategies are most helpful in sustaining programs. We interviewed 12 past SAMHSA targeted capacity expansion grantees as AOA and CDC grantees to gain their insights on sustainability. We had an expert panel to advise on the study. The report makes recommendations to both service providers and to funders on strategies they might use that have been proven successful to sustain programs. We create a sustainability framework based on the scientific literature and field experience. The literature offers 17 factors that support sustainability. We sorted the factors by those that relate to the program to be sustained, different factors that relate to the capacity of the organization trying to sustain the program, and third, to factors that relate to the community at large. The grantees we reviewed agreed that all factors found in the literature are important. The factors the grantees found most important are noted at the top of each list. Many factors are indeed strategies to sustain a practice, an intervention, or a program. While the slide is a little fuzzy and has a lot on it, I will now go through each type factor, and so you'll see it a little bit better. On the program factors, we looked at programs important for sustainability, programs that relate to impact and fit particularly. These factors need to be considered upfront when an organization is selecting a new intervention or program for implementation. You can see in the top items that interventions or programs need to have, 1, a demonstrated effectiveness, and 2, they need to be designed for results. Behavioral health interventions must have evidence of producing a health benefit. Organizations then need to show their implementation of the intervention is achieving the same impact as the original research. Staff and funders need to perceive and understand these benefits. In order to do this, organizations need to establish solid data collection systems, consistently collect and analyze both process and outcome data that measure results, and regularly update key stakeholders and the community about the program results. Additional important factors and strategies, an intervention or program must fit with an organization's mission, and the whole organization. As many of you know, when organizations start a new service that does not fit an organization mission, it often gets cut when times are tough. Financial resources and a financing strategy needs to be developed. Funds and staff need to know there are reasonable and what the articulated theory of change is for a program to achieve its impact. Program interventions need some flexibility. Many behavioral health interventions have several steps, like pre-screen, screening, intervention, referral. Some organizations have found collaborative partners to be effective for implementation. In this, partners might offer part or all of the intervention. And of course, human resources are important, including leadership, trained staff, and possibly outside specialists to advise and coach the implementation staff. Capacity factors that are important for sustainability include not only having program champions, but also making sure that the CEO of the organization is committed to the program and provides leadership. When conflicting priorities for funding, the CEO needs to lead or fully support the behavioral health program for it to be sustained over a long time. Call for managerial system support means strong fiscal management, accounting, information, and personnel systems. Organizations need to use these systems and understand the information they generate for considering improvement in operations. Program support systems are also critical, including training and technical assistance. Sustainability requires integration of the program in the organization, as an organization's stability and flexibility. To sustainability is developing a sustainability plan early and taking actions for sustained programs during the startup period and throughout implementation. Community support is another dimension that supports sustainability. Both community and state support is important. Resources and political legitimacy have been reported to be important as well. Just a bit of humor. Dinosaurs remind us that planning for sustainability must occur early. One says to the other, all I'm saying is now is the time to develop the technology to deflect an asteroid. The key things from our study are we've pulled you out for this webinar. In services into ongoing systems can be very useful. For example, depression care or expert screening, brief intervention, and referral to treatment for alcohol and medication misuse can be embedded in case management. By buying such practice into case management. It enhances the case management service of the agency. All one funding source is sufficient for sustaining service. Breaking is important, where fund streams like grants or payment for services are maintained separately but work together to support a program, to support the staff, to support the visits, to support the delivery of the service. So are often varied. There may be funds from medical services, mental health, aging services, all coordinated to fund depression screening and early intervention or other behavioral health interventions. We found that services that were sustained were often billable services, third parties like Medicaid or Medicare or private insurance. These services include care management, depression care management, therapy, and psychiatry. In creating a plan for sustainability, several key items are very important. Include planning with the partners in a community, embedding intervention in routine services, knowing the cost of sustaining the program intervention, investigating various public and private financial sources. Item, we need to know what needs to be sustained. Does the full program need to be sustained, or are there parts that could be let go? Sometimes a new payer system or funding source may have different requirements from the original intervention, like they require different staff credentials or the different number of visits. Adaptations to an intervention are needed. It's important to contact the primary program designer to review options for adaptations. It's important to learn what program adaptations may be made while maintaining fidelity versus when adaptation loses essential components or propensity to be effective. And as we've mentioned earlier, this report has a financial resource guide. The full report, again, is called Lessons Learned on Sustainability of Older Adult Community-Based Behavioral Health Services. This is a basic guide on grants and other financing sources. We add a page of information on the various sources. It is an overview intended to help people gain a general understanding so they have a productive conversation with funding source in their community or state. It covers private pay insurance, in the Center's Medicare and Medicaid services, and we will be hearing in depth about Medicaid later in this webinar. This suggests section includes information on the uniform block grants for mental health and substance abuse. Some states find older adult behavioral health to be a priority, and they in fact use block grant funds for prevention and treatment for older adults. We have information on screening, brief intervention, and referral to treatment, or SBIRT. Also will be discussed in detail later in this webinar. SAMHSA section also includes information on primary and behavioral health integration grants. As mentioned earlier, there are 64 grants around the country now. We discussed the mental health transformation grants award 2010 to 2015. There are 22 awards in play now, many of which have been very important in bringing out services for older adults. The full resource guide also reviews the Older Americans Act, and we'll hear about the various aspects of that act from Shannon Gawronski in a few minutes. The final resource guide also reviews additional federal funding from CDC, from HRSA, federally qualified health centers funding, USDA, state government, special taxes, philanthropic funding from foundations and United Way, and important partnerships for in-kind resources, such as partnerships with universities or health systems and others. And we mentioned social enterprise, where one group we found actually started a farmer's market to produce revenue stream to support this work. Study, we've learned about additional funding sources to support adult behavioral health. A couple of the current TE SAMHSA grantees bring some interesting funding sources to bear. In Michigan, the grantee has secured funds through the Affordable Care Act in the Care Transitions Initiative funded by CMS. In this situation, the Area Agency on Aging in the community is the lead agency. The triple added behavioral health coaches to the care transition model that they are implementing. The subcontracts with the SAMHSA grantee, which is a family service agency in Michigan. And the agency employs behavioral health coaches. Coaches visit patients in the hospital and later in their homes. The coaches arrange for behavioral health service from family service agency. And elder use funds are used to support gatekeeper outreach or client identification, as well as behavioral health services. Now turn to our next presenter, Shannon Gawronski, with the Administration on Aging in the Administration for Community Living. Shannon?
Thanks, Alex, for introduction. I'm Shannon Gawronski, and as Alex mentioned, I work in the Administration on Aging, which is a part of a new agency, the Department of Health and Human Services, called Administration for Community Living. At AOA, I work primarily with the health promotion programs, specifically in the areas of behavioral health and dementia. And today I'm going to talk a little bit about the Older Americans Act, which is the authorizing legislation for programs that AOA administers. I'm going to speak specifically to those parts of the Act which there is flexibility for states and agencies on aging to be looking at providing behavioral health services. Next slide, please. The Older Americans Act was passed in 1965, the same year as Medicare and Medicaid. Current mental health term appeared in the Older Americans Act 20 times, and the Act was last reauthorized in 2006. And there's more of an emphasis on mental health in the last reauthorization. The Act is currently up for reauthorization in Congress. Next slide, please. Title for the Older Americans Act includes a variety of different services that are funded. So as you can see on this slide, I've included three different parts of Title III that I think are most relevant to the conversation about behavioral health, as well as the fiscal 2011 funding amounts. So the first that I'm going to discuss, next slide please, Title 3B. And before I move on to the titles, let me say that with the Older Americans Act, it's not a specific funding source for mental health. So Title III, the parts of Title III I'm going to talk about today, states have flexibility to be able to deliver a variety of services, and many of them do deliver behavioral health services, but there's not one specific source of funding within the Act or that AOA administers for behavioral health. But there's lots of opportunity in Title III for states and community organizations to be able to work together on aging mental health issues. Title 3B is known as support services. Under Title 3B, mental health services are eligible for funding. Examples include mental health screenings, speech, education, counseling, and referral to services for treatment, as well as support for case management, in which some behavioral health interventions are embedded. A lot of the area agencies on aging do order determinations and correct for case management. So that's the primary services that's provided. To the next slide, please. Title 3D is the disease prevention and health promotion type of the Act. As of this year, due to change in the language for the appropriation for Congress, these funds are required to be used on all evidence-based programs. These include PEARLS, Healthy Ideas, and BRIGHT. You'll hear later on about some of these interventions on this call, as well as on other behavioral health programs that meet AOA's minimal criteria. And if you move to the next slide, there are some places, the first, where you can take a look at information about Title 3D on AOA's website. And it includes some frequently asked questions about the title, as well as some examples of programs that meet AOA's criteria for evidence-based and the different levels of the criteria. There are 3 of those. I also included SAMHSA's National Registry of Evidence-Based Programs and Practices, or NREP, many call it, which is another good source of information for evidence-based programs, as well as NCOA's Center for Healthy Aging website. Slide, please. Title 3E is the National Family Caregiver Support Program. These funds can be used to support behavioral health activities, specifically counseling services for eligible family caregivers. 5 services under 3E that are available in states, and that they need to be offering each of these. The service categories are counseling, education and training, and support group, under which these services are to be provided. Services related to behavioral health under 3E can include some of these that I listed on the slide. There's information to caregivers about behavioral health services, assistance in getting access to service, individual counseling, organization of support groups, caregiver training, etc. So there are a number of flexibilities within 3E to be working on behavioral health services. So a little bit more about 3E, and specifically about the data that AOA collects. So the primary data AOA collects from area agencies on aging, which deliver aging services with Older Americans Act funds, is state program reports. Those include information about who's receiving Older Americans Act services in the community, what kinds of services they're receiving, and what kind of funding is expended for each of those services. Our current SPR data shows that in 2010, states provided a little over $17 million of Title 3E dollars worth of counseling services to more than 123,000 family caregivers. So that comes out to approximately 427 units of service for the year nationally. On average, each family caregiver received about 2.5 hours of counseling services per year. One of the challenges with the state program report data we receive at AOA is that it doesn't include data so specific that we know the specific evidence-based interventions that states might be delivering, such as PEARLS or Healthy Ideas. But we do know, on conversations with states and with area agencies on aging, examples of states that are doing this, effectively, and I'm going to talk a little bit about two of those community examples. Next slide, please. So just a little bit, I mentioned that I'm going to talk about two examples, which are great examples of ways that aging service organizations working with behavioral health have been able to leverage funds to be delivering behavioral health services for older adults and or their family caregivers. Al had mentioned earlier that braided funding is really a strategy was identified by many of the states in the report on financing that NCOA worked with SAMHSA or funded by SAMHSA to do. And I think that this is something that I've been hearing from states that is increasingly critical, especially as resources are getting more and more scarce. And the second thing I'm really going to talk about is something that's not as resource intensive, and that is state area plans. In the Americans Act, there's guidance that is provided to states about requirement to create state and area plans. And I'm going to talk a little bit about what those plans entail and how community mental health organizations or others might be able to be involved in the plan such that mental health would be included as part of those plans. Many of them already included, but there are definitely some opportunities to expand that. So next slide, please. So Aging Resources of Central Iowa is a good example of a state that is offering two different mental health programs, Pearls and Healthy Ideas. So Pearls, which you're going to hear a little bit about later, is the program to encourage rewarding lives for seniors. The Depression Care Management Program, again, you're going to hear a little bit more about that later. So the state of Iowa is working with their Pediatric Education Center, who received a Health Resources and Services Administration grant to be able to develop the Pearls program within Iowa. That really, the start of that relationship really initiated the program within Iowa through Aging Resources of Central Iowa. The state then went on to use really two different funding sources to be able to administer and then expand and sustain the program, being Title III-D funds from the Americans Act, as well as some county funding. The second program that Resources of Central Iowa is delivering is Healthy Ideas, which is identifying depression, encouraging activities with seniors, which is also a depression care management program for older adults. And again, Iowa is using a few different funding sources, including Older Americans Act, Title III-B funding, as well as some elderly waiver funds for case managers. This is a program that's embedded within case management. Included a link where you can find more detailed information about what Iowa is doing. It's a webinar that they did, and you can find a transcript as well as a video of the webinar on the website that I've put on here. Slide, please. Second example is the Camarillo Healthcare District, with a community organization in Ventura County, California, provides a variety of services. I'm going to talk more specifically about some of the programs that they deliver that are related to behavioral health. The healthcare district received 3 grants from the Area Agency on Aging in Ventura County in order to provide 3 different types of programs. So the first is they're providing a support line. The line is really designed to provide a telephone support for seniors who are at risk of isolation, victimization, maybe they have other health concerns. For the line, the health district is working with volunteers, University of South Carolina, Los Angeles, as well as interns. We're working under the guidance of a licensed psychologist. And really the program is to help promote security and verify the well-being of seniors. On support line, the Patient Health Questionnaire, or PHQ-2, which is a basic screening for depression, is delivered by those case managers and interns that are having the line. And those who screen positive on that brief screening for depression are referred to additional screening and services. The grant that the Health District received, which was from Area Agency on Aging of Title III-D funds, is to deliver healthy ideas. That grant was just received at the beginning of this year, and that program is currently being developed within the agency. And the third program that the Healthcare District received Title III-E Older Americans Act funding for the Wellness and Caregiver Center of Ventura County. The center was really developed to provide support for caregivers. It's practical, compassionate, and reality-based, and specifically looking at support caregivers that have ongoing health conditions. And I included contact information for one of the resource officers at the Health District, as well as a link to their website where you can learn more about the services that they offer. Slide, please. Finally, I mentioned area plans. So within the Older Americans Act, states are charged with developing state plans on aging, as well as working with their area agencies on aging, so to develop area plans. And each state has a plan on aging, and within their states, the area agencies on aging are also develop plans. Plans are for 2, 3, or 4-year periods. And that cycle or that frequency of update is determined by the state agency on aging. And each AAA develops a plan and sends it to the state for approval. And I've included the language in the Older Americans Act related to area plans. And as you can see, mental health services are something that the area agencies on aging are really charged to being about and looking at supporting within their Americans Act services and the other services they're providing. So I think that's my last slide. So I'm going to turn the presentation over to Ian Close, who works in the Division of Benefit Coverage at the Centers for Medicare and Medicaid Services. And I'd be happy to entertain questions at the end of the webinar. Thank you.
Thank you. It's a pleasure to be with you today. I'd like to start off by building on 2 points Alex McNeil raised earlier. To sustain a program, it's really useful to embed services into ongoing systems, and secondly, to identify more than one funding source to sustain services that really make a difference to older people and people with disabilities. Today, I focus on one ongoing system, Medicaid, which is the primary source of reimbursement of medical assistance for older people and people with disabilities. While I'm discussing some of Medicaid's parameters and new authorities through the Affordable Care Act, I'm hoping that this information will provide food for thought as you plan for the sustainability of activities that really make a difference in the lives of the people that we serve. I'd like to use the earlier example of a program to illustrate some of the points on the next slides. You have developed an effective program to address depression in older men and to prevent suicide. Your grant will be ending in 3 years. Can you sustain this program? First, understanding what Medicaid looks like in your state. Medicaid is truly a state-federal partnership. State for up to 50% of the cost. The official document that describes your state's Medicaid program is called the Medicaid State Plan. It's the agreement between the state and the federal government describing what services are covered, for whom, and how. You may also want to identify a champion for your suicide prevention effort with your state's Medicaid agency. So it may help you understand how primary and behavioral referral services for older people or individuals with disabilities are reimbursed currently by Medicaid. Be prepared to share a cost-benefit analysis that you've developed through your demonstrations experience. I'd like to focus on reimbursement parameters. Section 1902-830 of the Act has some important guidelines consideration. Let's say there's a state interest in pursuing a suicide prevention initiative. This slide lists the key Medicaid reimbursement parameters. Medicaid reimbursement is available for covered services, and we'll discuss what these are next. For example, reimbursement may be available for substance abuse therapy, but not the printing of provider manuals or substance abuse therapy. Medicaid reimbursement is for services to the Medicaid-eligible participant. For example, reimbursement could be available for needed individual therapy for the participant with depression, but not for his non-Medicaid eligible son who lives with him. Medicaid reimbursement is available for medically necessary services. For example, home services are reimbursed under a physician's order as part of a plan of care. However, reimbursement is not available for bariatric surgery, let's say, when a person's weight is under the limits established by the state Medicaid agency. May be made only for services to individuals that meet the state's Medicaid eligibility criteria. Individuals must meet the requirements of a Medicaid group as well as income requirements. In 2014, states may expand eligibility to a new group of individuals, a group of adults, thus expanding access to essential health benefits for many individuals served through the aging network currently. These benefits must include mental health and substance use disorder services. Let's go a little bit more about the service requirements. Reimbursable services need to be provided in an amount and for a duration that's sufficient to achieve their medical or remedial purpose. The state must not be arbitrary or deny a service based on type of condition. Like to our example of a special program for men at risk of suicide. Based on these provisions, are there any implications for program design and reimbursement? The waivers of statute, a service cannot be targeted just to men or to older men or to individuals with depression. And it includes a list of services that are mandatory under the Medicaid program. And you'll note these are really similar to what you may have in your health insurance menu. In fact, example of a program for addressing depression and suicide among older men. A few services could be brought in such an initiative. For example, hospital care, physician services, and services of fed qualified or rural health centers. The following slide shows a list of optional services that states may or may not cover, related to our example of a program for addressing depression and suicide among older men. Components of initiative that could be reimbursed under Medicaid may include services of licensed practitioners such as LCWs or psychologists, prescription drugs, targeted case management services, inpatient hospital services, hospice, personal care, and preventive services. And yet there's still more optional state plan services. In recent years, and particularly with the passage of the Affordable Care Act, new options for delivering services have emerged. Certain statutory provisions are built into these services, and the services can be provided under the state plan without budget neutrality, cost effectiveness, or cost neutrality requirements. Let's discuss a little bit more about some of these opportunities. The Affordable Care Act provided new flexibilities to serve individuals with behavioral health needs through Medicaid. And for some options, incentives were included that encouraged states to take on these new opportunities, even in difficult budget times. One new authority that was included in the Affordable Care Act was health homes, a potential for serving all the needs of individuals with chronic mental illness. Health homes include comprehensive care management and health promotion. Homes also include comprehensive transitional care, which includes follow-up from inpatient to other settings, individual family support, to community and social supports, and the use of health information technology to link services. Health homes service individuals with chronic conditions, including mental health disorders, substance use disorders, asthma, diabetes, heart disease, and being overweight. Now, if provided by a state, health home services may not target specific individuals, conditions, or populations within these chronic conditions. Now, they make medical assistance payment for health home services delivered by a designated provider, a team of healthcare professionals operating within a designated provider, or a health team. Provided be reimbursed in two ways: a tiered payment methodology that accounts for the severity of each individual's chronic conditions and capabilities of the designated provider. This method provides that states may limit or submit alternative models of payment that are not limited per member per month payment. States offering health homes receive consultation from Substance Abuse Mental Services Administration, SAMHSA, to address issues of prevention and treatment of mental illness and substance use disorders. Health homes address access to a wide range of physical health, mental health, and substance use prevention and treatment services. The approach includes screening for alcohol and certain drugs, identifying available mental health and substance use abuse services, care planning that integrates physical and behavioral health services, referral and linkage to other specialty care, behavioral health, and community supports. Medicaid program offers additional flexibility through their waivers. Sometimes these programs are known as waiver programs, and this term refers to waiving provisions of Medicaid statute. This slide lists 5 programs where statute is waived. For example, 1915A waives individuals' free choice of provider, and enrollment must be voluntary. 1915B also waives individuals' free choice of provider, but enrollment may be mandatory. 1915B also waives statewide-ness, so you can focus in a particular geographic area, for example. 1915C, which many on the phone may be participants or providers in, waives ability and statewide-ness and enables states to offer a different set of services to groups meeting an institutional level of care. A of 1915C, 1959 provides this ability within the state plan, and an institutional level of care is not applied. Now, Section 715 is used for demonstrations and research in order to promote the purpose of the Medicaid program. This authority provides the greatest flexibility through waiving other provisions of Section 1902 of the Social Security Act. So, to conclude, in going back to our suicide prevention program for older men, in designing this program, I would revisit the points made in the original presentation and suggest a plan for sustainability during your grant development and program design phase. In addition, consider embedding these services into ongoing systems, as well as identifying more than one funding source to sustain services that really make a difference to older people and people with disabilities. Your states and CMS regional and central offices are key resources in your planning. I'm happy to help as well, and my contact information is included on the following slide, and we would be happy to hear from you. Continuing on with some examples of programs is Leslie Steinman with the Motion Research Center with the University of Washington, who will be talking more about finding evidence-based practices for depression for older adults. Leslie.
Thanks to EOA and SAMHSA and NCOA for inviting me today. I also want to acknowledge my colleague Nancy Wilson at the Baylor College of Medicine and the Houston Center of Excellence in Health Services Research for slides and for her input on the Healthy Ideas program. So we'll be reviewing financing for evidence-based depression programs for older adults, and you'll see some of the factors that have been identified by the earlier speakers in terms of thinking of key factors for funding and sustainability. So first, to tell you a little bit about PEARLS and Healthy Ideas, the 2 evidence-based programs I'll be speaking about today. These are what's known as home-based depression care management programs. Depression management is based on the chronic care model, which includes several components. One is active screening for depression. So depression, especially minor depression, is under-recognized around elders, particularly homebound elders who don't present often in primary care clinics or who present with multiple comorbidities. And so the first component of depression care management is really screening for depression and finding folks who have depression in the community that you work with. Next, measurement-based outcomes such as the PHQ-9 or GDS-15 is used to standardize how you assess both baseline depression in your population and then changes throughout the program. And these are tools that are usable by trained staff, including paraprofessionals. Another component of the depression care management model is having a trained depression care manager. This is usually someone who is at your agency already, so they're familiar with the agency, how it works, and the population that it serves. And they provide both client education and self-management support to client, as well as delivering evidence-based treatments for depression, such as problem-solving treatment and behavioral activation. Other pieces of the care model that depression care management include consultation or case supervision, so having a psychiatrist or another clinician who can really work with the counselors to help address common medication issues and other issues that come up, questions around depression treatment and other chronic conditions. A step care approach, so really being able to work with the client where they are, providing some follow-up after the intervention's done, providing more or less intensive services as needed, and really doing a better use of resources and connecting to other services. Both interventions are brief, they're delivered over several sessions, they're practical and evidence-based. We have information suggesting that they have improved depression and also other outcomes in older adults, such as quality of life and well-being. About these programs at the websites listed here today, and I'm also happy to answer other questions at the end of the webinar or offline. So programs funded. They're currently being implemented over 100 sites in 26 states, and these include agencies on aging, senior nurses, community centers, and community mental health centers. Pearls and Healthy Ideas use braided, diverse sources of funding. This has been talked about previously today. There's not just one funding source typically that's used to support the programs. So some examples are listed here. As discussed, the Older Americans Act provides support for case management programs through agencies on aging and through family caregiver support programs throughout state and local agencies. Triple have discretionary funding that they choose to put towards these programs because they see depression as a key issue in their community. Cited support for Pearls and Healthy Ideas through mental health funding to states and through the Older Adult Targeted Capacity Expansion Grant Program, or TCE program. And there's been funding through Medicaid, home and community-based services, case management programs, and client training services, and also through Medicare as well. Additional funding sources include state funding sources for case management and for mental health services. There's also been funding through United Way funded programs, so there are several United Way funded nonprofit case management programs as well as community centers that we work with. Regional foundations have also been a key source of funding, foundations in the area that may be interested in addressing aging issues or mental health issues in your community. Several nice examples of funding that's been what we refer to as voter-approved funding. So these are local or state levies or taxes that have been used specifically to fund these programs. So a couple of examples include locally here in Seattle-King County. Back in 2008, there was a levy for Health and Human Services, which specifically runs Pearl services to veterans, spouses, and to racial and ethnic minority groups in this area. In California, the voters approved a 1% tax on millionaires called the Mental Health Services Act, and that funds several Pearls programs across the state of California. Example for funding includes university research and education grants. So we heard earlier about the University of Iowa, which was able to work with their local education geriatric center at the University of Iowa to fund their startup for Pearls and for Healthy Ideas. We've also received locally Pearls translational research funding from CDC, which has helped us support the local Pearls program or area agency on aging. Nonprofit organizations can use their discretionary funding to support Pearls and Healthy Ideas. These include community centers and other programs that typically target specific communities in their area. So many examples of how Pearls and Healthy Ideas have been funded, starting with Pearls, Washington State. The state Medicaid plan covered only major depression funding. You heard earlier from Jean, she spoke about one of the Medicaid waiver programs, the 1915C, that some states can apply for to use to cover other services for populations that are eligible for institutional level services. What happened was several years ago, our state unit on aging worked with the state Medicaid office tasked the Medicaid community-based services waiver to fund PEARLs. What they said was that clients were currently being screened for depression, but that many of them had depression that was not being treated. The prevalence for depressive symptoms in the long-term care population was 6%, and 1/3 of these clients were taking antidepressants. So even though they were being treated for depression, some of these clients, they weren't effectively being treated. What they did is they decided to apply for Medicaid waiver funding to cover client training services to cover programs such as PEARLs, which provide skills training to address minor depression. And this was a unique and creative way of thinking about PEARLs because it really focused on the empowering and skill-building aspect of PEARLs to really address a gap in mental health funding for covering minor depression in this community. This also covers another evidence-based program, the Client Disease Self-Management Program that you may be familiar with. So moving to the next slide, the waiver unit cost was developed based on a pilot with the King County Area Agency on Aging. And they needed not to just cover the in-person PEARL sessions, but the time and resources needed for screening, for program eligibility, counselor supervision, and travel to and from the home. And they said the population density of the Seattle-King County area with many potentially eligible depressed clients really supported this Medicaid waiver as an economic model. Or you can see the link on this slide here, or I'll be happy to answer any questions later. The example is looking at Harris County, Texas, and this is thinking about the Healthy Ideas program. So several nonprofit United Way providers are working together to provide a coordinated access network through the Care for Elders Partnership. These include Sheltering Arms, Catholic Charities, and Family Services of Greater Houston. These three agencies are serving a diverse aging population, and working together, they've been able to fund and sustain their Healthy Ideas program. They've received foundation and EOA grant support for initial work to establish Healthy Ideas programs, to depression into their routine programs within each agency, and to data systems to track client process and outcomes. So this is the foundation for not just implementing the program, but really sustaining these programs. They then get joint required training of program supervisors and staff across multiple agencies, providing for more efficient use for training resources and staff time. And the training also had agencies working together from the beginning. Last, set up clinical coaching through reciprocal agreements with their local academic partners. And so with academic partners, either locally or via Skype or conference call, can be a really affordable way to provide excellent clinical supervision and coaching to program staff. Work with academic partners also is important, as one of the speakers referred to earlier, when you're thinking about how best to adapt the program to meet your needs, but still meet fidelity to the original program model. Agencies continue to regularly as part of their access network, providing a feedback loop for sharing success stories with implementation, ways that they've addressed common challenges. They provided booster training for new staff as new knowledge is learned about program implementation. In addition, the ongoing tracking of depression outcomes has really led to ongoing support from United Way. United funds case management services that are inclusive of Healthy Ideas because these agencies were able to show outcomes for clients that got added support for case managers to support their salaries. Previously, when United Way went to an outcome model, they didn't have a way to show outcomes. This is really exciting. I'd like to turn it over to Stephen Fuente from the Florida Bright Program.
Thank you very much, Leslie. So what to share with you this afternoon is the experience in the state of Florida, specifically with the Florida Bright Project. I had the opportunity to serve on the core state committee that helped establish the Bright Project, as well as administer the first pilot, which is still sustained today. And talk to you a little bit about this initiative from the standpoint of its current funding and sustainability. Next slide, please. The Bright Project was a statewide older adult initiative, BRIGHT standing for Brief Intervention and Treatment for Elders. Specifically, the project focused on early intervention and response to elders that suffered with substance misuse issues and other related behavioral health problems. The project actually used the ESPER evidence-based model as its intervention approach, and it encompassed screening, assessment, brief intervention, referral, and treatment, focusing primarily on alcohol misuse, prescription drug misuse, illicit drug misuse, tobacco addiction, and depression, as well as some ancillary behavioral health and elder-related support services that many of the individuals served required. When we implemented this project, the state implemented this project in a standardized protocol and training format to maintain fidelity to the ESPER model. Next slide, please. The implementation of the Florida Bright Project, there were 4 pilot sites. So for these 4 pilot sites initially came from the State Substance Abuse and Mental Health Program Office, and the source of that funding was state general revenue. The state applied for a SAMHSA grant, which it received, a 5-year grant, which allowed the state to expand the number of sites from 4 to 21. Next slide, please. In September of 2011, it was 1 month prior to the SAMHSA funding cycle ending, and a statewide survey was conducted with the 21 Florida Bright sites to determine their efforts with respect to developing sustainability plans, as well as their ability and success in identifying continuation funding. 9 of the 21 Florida Bright agencies responded to the survey. 4 of those agencies at the time did have the ability or had not yet identified available funding to sustain their project. 7 agencies indicated that they would be using other funding than the federal funding, that they were successful in identifying a source to sustain the project. The agency indicated county funding as a source of funding to maintain their project. Another agency indicated they would be billing Medicare as well as billing other insurance. And one of the agencies indicated that they would be utilizing the ability to have some older adults who had the resources contribute towards their care in a private pay and sliding fee scale model. You can also see that we certainly have more than 19 in adding up these agencies that responded, so some of them were looking at a mix or blend of funding to sustain their project. Next slide, please. Right today, probably a year after the survey was done in 2011, there are 5 of the 21 Florida Bright programs still fully functional, still fully funded, and maintaining themselves at full program fidelity. Of these 5 sites, 4 of the agencies were successful in obtaining state funding, substance abuse and health block grant money to sustain the project. The agency that indicated that they would be using county funding to sustain their project were in fact doing so. And of the 4 agencies, some besides state money also were utilizing foundation money, United Way money, and even indicated currently that through donations and private pay, they were able to maintain full funding of their project. A thing that was brought up consistently among the sites was that they were all partnering with universities for graduate interns, use that as a resource in sustaining their project. Next slide, please. Some other concepts that were brought up in follow-up with the Florida sites that were very much related to their sustainability issues included that in speaking with some of the sites that considered themselves to not be funded any longer, they still had embedded some of the programming that was part of the Florida Bright project to their existing operations. So although they weren't fully funded or fully functional and were not at the full program fidelity model, they were in fact including pre-screening, One of them had continued the depression screening and primarily in a collaborative with hospital district, and one was continuing to use motivational interviewing in the health education component, which was part of the brief intervention with their current service system. So what was evident in these unfunded initiatives, as well as evident in the funded initiatives, is that they continue to find ways to embed the programming that was part of the Florida Bright model into their existing operations. And since this model relies heavily on collaboration with other community agencies, many who responded in a positive way with respect to sustainability, even if it was only at some program level, continued to indicate that some of their collaborative relationships allowed for continuation of referral at a minimum, some pre-screening, and certainly identification of elders at risk. What seems untapped in what you have heard thus far in this webinar is use of Older Americans Act money and Medicaid funding in the state of Florida. Both these sources have yet to be tapped into and were not currently used. Another important ingredient that was brought up by sites was the issue of sustainability in business planning even prior to starting the program. Sites realized that as they were thinking of developing this program or operationalizing this program, that was actually the time for them to begin the process of thinking about sustainability in business planning, to begin some form of outcome measurement, and to use outcome measurement that was occurring within the program to demonstrate the value added and really to market the program, and to incorporate activities like cost-benefit analysis so that they really arm themselves with objective information that would be successful in obtaining future funding for the initiative. Next slide, please. One of the things that I wanted to share with you in terms of other sustainability and funding considerations include commercial insurance, Medicare, and Medicaid. And what you see in this slide are the codes, the actual descriptions of the funded service, and the current fee schedule associated with that funded service. And certainly I believe, as you've heard in this webinar, with respect to Medicaid, it would be very important for you to contact the leadership in your state in this area to determine the feasibility and the availability of Medicaid funding for this type of initiative. Next slide, please. I just wanted to share, to sort of wrap up the presentation, billing codes that are associated with behavioral health services. This may be quite helpful in determining what are potential billable services that are in line with the types of programs and the interventions the programs use that we've been describing and providing to you on the webinar today. And certainly, as others, I remain available and I'm willing to provide any additional support as needed in answering questions or follow-up with respect to assisting organizations and states to sustain behavioral health older adult services. Next slide.
And this
I was just going to turn it over to you. So.
Thank you. This is Ed McNeil. I'm coming back on the line to offer some wrap-up slides. Before I do that, I want to encourage you to send any questions you might have to us. We just one at the moment. We'd really appreciate receiving some more. You just drop the chat box down from the middle of the top of your screen. In a question, we'll have our panelists discuss them in a few minutes. I'm going to offer a few wrap-up points of takeaway messages from each of our speakers. From my presentation, I hope that you are interested in downloading the SAMHSA NCOA Lessons Learned on Sustainability of Older Adult Community Behavioral Health services. It's on NCOA website, www.ncoa.org. You can enter the name of the there. This report includes the sustainability framework that identifies factors and strategies to select, finance, and maintain evidence-based programs. It also includes a resource guide outlining potential financial resources. We then heard from Shannon Gawronski, the Administration for Community Living. She talked about behavioral health funding available through the Older Americans Act, and she told us about the various elements in Title III that support behavioral health. She went on to give us some examples of organizations that in fact have used 3B, supportive services, and senior center program funding, Title 3D, disease prevention and health promotion service funding, and 3E, National Family Caregiver Support Program. So funding is there. It's a matter of discussing this with your local area agency on aging and finding a champion in that agency around behavioral health or helping to create one, and also perhaps speaking with your state. Also then gave us information about the state and area plans and the importance of mental health in these plans. We next heard from Jean Close from CMS, who reviewed Medicaid supports to state efforts to finance older adult behavioral health interventions, looked at mandatory and optional services, optional state plan services, including 1915 waivers for home community-based services, so under J for self-directed personal care, and also K, community first choice. She then us on service options for integrating services, home and community-based state plan options, and enhanced FMAP funding to states to modify service delivery systems. She discussed the home health option for individuals with multiple chronic conditions or serious mental illness. Brings along increased FMAP financing as well. Simon then reviewed financing of evidence-based depression care programs in aging and other community services, looked at pearls and healthy ideas as models for depression care in community agencies, relayed to us the many federal, state, local, and private sources that are funding these services. She had a couple of good examples on how different states and communities are approaching financing, how PEARLS is financed in part in Washington with Medicaid financing as one of many funding sources in the state of Washington. And she looked at the ideas in Houston, Texas, where the United Way and Older Americans Act financing are used to support the work. Like Stephen Ferrante with Group Victory and the Florida Atlantic University, refinancing for screen brief intervention and referral to treatment for alcohol and medication misuse. Provided an overview of the BRIGHT program in Florida, which is an adaptation of SBIRT. He relayed Florida SBIRT being sustained in several sites that were initially started with demonstration funds. It's being funded today through money that the state of Florida receives from SAMHSA through substance abuse, mental health block grant funding. Also, local grants and graduate interns are being used. He noted how SBIRT is sustained in many states with commercial insurance, Medicare and Medicaid, and grants. And various states turn on the SBIRT option for Medicaid. Many states have, some have not yet. But it's important for you to speak with your Medicaid office to see if it's turned on in your state. So we're going to turn to some questions. We have one question for Jean Close from CMS. The question was, CMS wants screening brief intervention integrated into all primary health care practices by 2014 due to the Affordable Care Act. Jean, will you answer that, please?
Sure. I think it's a good question. I'm aware of no requirement under Medicaid that a specific practice be integrated into primary care practices. As I mentioned earlier on, Medicaid is a very flexible program, and going along with that is that states have programs differ, and behavioral health services are optional services that are reimbursed by state. So every state is going to be different, as well as providers, perhaps under managed care authority, what providers are tasked with covering in their practices. So again, I would suggest contacting your state Medicaid agency, finding out more about what services are provided, and go from there. But there's nothing to say that a reimbursement would not be available, but such activities are at the state's option.
She'd also like to ask you about Community First Choice. Would you like to tell us something a little bit more about that program?
First Choice is a new program authorized under the Affordable Care Act, and it's just a great opportunity to provide person-centered services to individuals in their home with the assistance of attendant care. The one thing I think that's particularly strong about this program is that the participant really is in the driver's seat as far as identifying their attendant, as far as and the scope of activities that the attendant would provide to them. In addition, their reimbursement would be available for related activities to support that individual as they stay in their own homes in the community.
Another question, and it's Shannon Gawronski. What happens when the area plan determined by the Agency on Aging expires?
That's a good question. So each year AOA works to develop guidance for the state the plans as well as the area plans that really provide a framework for thinking about how states might be developing their plans and outline some of the requirements from the Older Americans Act. And so we provide some technical assistance along with our partners at the National Association of States United for Aging and Disability, as well as the National Association of Area Agencies on Aging, to help states in the development of those plans and the vision of those plans. So when an area plan expires for the state or the area agency on aging, they have the option of looking at their plan and taking a look at the guidance and then resubmitting their plan. Now, states, as I mentioned, determine the frequency in which they're asking the area agencies on aging to reevaluate their plan. States will also provide their own guidelines to area agencies on aging, in addition to, or including, maybe a better way to put it, the guidance that AOA provides. So I guess that the 2, 3, and 4 year cycles, people can either revise their plan and resubmit it to the state in their timeline, or they can continue with the same plan. It really is up to the state to set the time frame as well as provide the specific guidance for the agencies on aging.
Thanks, Shannon. And we have a question for Jean from CMS. Jean, are Medicaid state plans available for public review? And if so, where can this participant find their state plan?
For the most part, the Medicaid agency has these online these days. Now, there's a few states that don't, but I would suggest going there first because many states are moving in that direction. But you want to contact your state Medicaid agency, and if it's not available online, then certainly these are public documents. Now, I have to warn you, they can be like 1,000 pages long because they describe all aspects of the program. So when you make your request, narrow it down to what particularly you're interested in. Perhaps you're interested in knowing what services are covered, and that'll assist your contact at the state to provide the information that you need.
And we have a question for Stephen Ferrante. Who is the typical lead agency for a Bright intervention?
In Florida, it was actually a mix. Some of the lead agencies were area or region's primary aging service provider whose primary service was case management. Other parts of the state, the lead agency was a substance abuse service provider. And there were a few initiatives, only a small handful, where primary care physician group was the provider. The most common was the aging service provider.
Thank you. I'm wondering if any of the presenters have questions or would have another point they'd like to make. We have a few more minutes. We'll see if more questions come in. But do the presenters have a question of each other, or is there a point that the time limit didn't allow you to make earlier?
Even I think someone is inquiring whether Florida Medicaid pays for ESPR, and at this point it does not.
Man, there are a couple of questions, Alex, that are showing up on my screen. I don't know if they've been answered yet. One of them was, did the state examples sustain start with the federal grant? And they did, a number of them. And at least here at SAMHSA, we're spending more time and energy and effort working with our grantees to sustain their programs. It's always been part of the request for applications to ask grantees how they plan to work on sustaining, but we're really focusing much more so on that, particularly as we move towards the changes in the Affordable Care Act. So many of them did start with federal grants. Some of them, such as the Bright projects in some of the other states, I'm not sure. Stephen could probably speak to that.
Bright project started initially with general revenue, but really the expansion and functional statewide initiative was the result of federal funding, a SAMHSA grant, a 5-year SAMHSA grant.
Thank you. We have a question for Leslie Steinman. Was Washington Medicaid 1950C waiver program with supporting pearls for individuals at a nursing facility level of care?
They required both assistance in at least 2 ADLs, and then also it could be a nursing home level of care. Most of the people receiving the program, though, do live at home in the community.
Thank you, Leslie. And the next one, did most of the state examples that have been, no, I think we picked that one. Most of the examples start with a demonstration grant. Many of the ones that started with AOA funding were initially demonstration grants, but not all of them. Pearls got started with a grant from CDC, which was a research effort. The University of Washington took initiative working with the Area Agency on Aging in Seattle to take what known from the literature and apply it in a local situation with older people and use CDC research funding as initially. Since that time, the AAA has funded Pearls in Seattle with its own funding and state local funding, as Leslie has mentioned.
And Alex, I just wanted to mention, this is Shannon. In the Iowa example, they had partnered with the Geriatric Education Center, the University of Iowa, through a HRSA grant to develop their Pearls and Healthy Ideas official implementation of those programs.
Thank you.
That's another option. If you go to HRSA's website, you can find out where those geriatric education centers are, because there are multiple ones across the country, and they might be a good partner if you're thinking about behavioral health programs or even others as well.
I've heard in North Carolina they're doing that as well. The geriatric education centers are partnering with aging services to take healthy ideas to a number of communities in North Carolina. We have more questions, which is, do we know who this is to? Can you point me to states where the Mental Health Authority and the Substance Use
No, the State Unit on Aging.
And the State Unit on Aging are working together persons with serious mental illness? We know in the state of Missouri that's going on. The Unit on Aging.
Marion, and I think in Ohio, we had a couple of grants, SAMHSA's targeted capacity expansion grants. We had a couple of grants that focused specifically on serious mental illness. But at that time, we were working directly with community mental health centers. We weren't emphasizing partnership as much. So I don't know for sure if there was a partnership in Ohio, but I believe there was. The other place that we worked with that served older persons with serious and persistent mental illness was Jacksonville, Florida. That was a SAMHSA grant. It was not established through a partnership at the state agency level. I'll be able to answer that question later if you send an email, Marion.Scheinholz, the address, my name that you saw on the thing, at samhsa.hhs.gov. We're meeting with various states and departments of aging and mental health, and we may have an answer to that for you when we finish up our series of meetings at the end of the year.
In the state of Michigan, the Unit on Aging and State Mental Health Authority are collaborating around working with people with serious mental illness, working particularly on their chronic diseases and self-management of chronic diseases. So it's exciting to see how the State University Chronic Disease Self-Management Program is being used with persons with serious mental illness across Michigan. This is a peer-led program. Now, the health benefit that it's delivering is self-management of chronic diseases, which could include a behavioral health problem, but also would include other chronic diseases. So I think that we have one more. It's the likelihood that SAMHSA will reissue the expert RFP. Mary, I don't know
the answer to that. No, that's SAMHSA's Affordable Care Act coming. SAMHSA's emphasis in many ways will change to the people who are not covered by that change in healthcare reform, if in fact it does go thoroughly through. So the best thing to do is to watch the SAMHSA grants, SAMHSA webpage grants, and the grants are announced there throughout the fiscal year.
And states currently have the SBIRD grants, so, and those are listed on the website, the SAMHSA website, so we would really encourage people where there are SBIRD grants to talk to whoever's leading that work in your state. And most states have had SBIRD grants at some point, so there's some history of SBIRD going on in most states at this point in time. Also, JBS International provides technical assistance on SBIRD, so you could send Donna Sue, who helped register you for this webinar, a question, and we will also try to find that information. But of course, we support Miriam's suggestions that we watch the SAMHSA website and the announcement for grants. I'd like you to know that the next webinar in this series is scheduled for Wednesday, November 14th from 2:30 to 4 Eastern Time. We'll discuss behavioral health issues with family caregivers as clients and partners in care. Everyone who is registered for this webinar today will receive registration information for the upcoming webinars. In January, we will repeat an earlier webinar on suicide prevention and invite you all to participate in that as well. You can access this and other webinars and related issue briefs on the old Administration on Aging website, behavioral health page, as well as on our partner website. And the partners are the National Council on Aging, the National Association of States United for Aging and Disability, and the National Association of State Mental Health Program Directors. In the future, we expect that these web and issue briefs will also be on the SAMHSA website. So I'd like to once again thank all the speakers and thank all of our participants for joining us this afternoon. Good afternoon.